Ankle posterolateral approach. This provides exposure to the posterior malleus, posterior ankle joint, lateral or posterior fibula, peroneal tendons, and then retinaculi. Internervous plane is between flexor hallucis longus, which is supplied by tibial nerve, and peroneal muscles, which is supplied by superficial peroneal nerve. General anesthesia or spinal. Position is prone, lateral or supine. Large bump will be needed under ipsilateral hip to allow access. Tourniquet is applied. Incision made along posterior border of the fibula, typically centered above fibula fracture if present. Need to extend almost to the tip of fibula to access deeper structures. Superficial dissection down to the fibula. Access to fibula is done with superficial dissection down to lateral or posterolateral fibula, which is subcutaneous. With proximal dissection, care must be taken to minimize risk to the superficial peroneal nerve. Deep dissection. Excess fibula is obtained with posterior retraction of the peroneal longus and brevis muscle tendons. Access to the posterior malleus. Access to the posterior malleus is obtained with anterior retraction of the peroneus longus and brevis tendon. Identify interval between flexor hallucis longus and peroneal tendons and bluntly split alveolar tissue. Elevate FHL off the distal posterior tibia. Retract the FHL medially to allow access to the posterior malleus. Care must be taken not to retract posterior inferior tibiofibular ligament off the fragment. This devitalizes the posterior medial malleolar fragment and can lead to post-fixation syndesmotic instability. Danger is superficial peroneal nerve, which is risk in superficial dissection. Then the posterior tibial vessels should remain protected behind FHL. Tibial nerve should remain protected behind FHL, and sural nerve is at rest with further dissection distally.